Dr. Thegesha Naidoo. Welcome to the show. Thanks for being my second general surgeon on the show, hot off the heels of my good friend and your friend and colleague, Dr. Kafis. Let's jump in. What does a general surgeon actually do?
Sure. I think a lot of people actually ask that because they get very confused with, I think, general surgeon. So essentially a general surgeon forms the basis of all surgical procedures, I think.
It's a specialist.
It's a specialist. So you have to specialize for a certain amount of years. You have to write, obviously, exams.
Yeah.
And then you become a general surgeon. So a general surgeon is essentially a specialist, just like a plastic surgeon is, just like a urologist, a neurosurgeon.
Yeah.
So a general surgeon is...
So what do you do? Why do they call it general?
So you don't focus on a specific aspect. You work on essentially every target organ of the body.
Okay.
But then
From
once
head to
you
toe.
become... Yeah, well, you can do a lot of head to toe. Certain areas obviously are specialized for the neurosurgeon, certain things you won't do. But once you become a general surgeon, you can then subspecialize. So you can look at only the vascular system if you become a vascular surgeon. So you do general surgery first, and then you subspec.
Yeah. Okay. So what do you do?
HPB.
What do you do?
So as a general surgeon, a little bit of everything. You're a jack of all trades.
Yeah.
Not necessarily a master of none.
Yeah.
But so for everyone watching, an appendicectomy, laparoscopic cholecystectomy.
What are these things? I mean, remember, you're speaking to a layperson, yeah, so...
Okay, so removal of the gallbladder.
Okay.
So if you have gallstones and you have a lot of pain, can remove the gallbladder. Someone comes in with an infected appendix, take them for an appendicectomy.
Yeah.
Trauma. So obviously you do have a trauma surgeon, but in South Africa, I mean, doctor to patient ratio is difficult to deal with. So the general surgeon also does trauma. So if you look at the systems of the body, a general surgeon would also do stepwise down the breast. So patients with cancer, patients with breast disease, go down to the abdomen. You would do, as I said, appendicectomies, take out the appendix, take out the gallbladder, look at the intestine, so bowel.
Yeah.
So anything to do with that. Remember, you also have skin.
What type of trauma?
So trauma is a big thing in South Africa. So we see a lot of gunshots, a lot of stab abdomens, a lot of crush injuries. So you get polytrauma. Patients involved in motor vehicle accidents come in polytrauma. So they might have a head injury with concomitant abdominal injuries. So maybe the intestines are injured. Maybe they have a vessel injury. So a lot of that. And that's all during your formative years as a registrar.
Okay. I was going to keep these questions till the end, but I said, let me switch it up a bit. I asked the viewers and the listeners if they would have a question, if they could ask a question of a surgeon, what would they ask? Just one question. So I'm going to go through some of the responses I got.
Okay.
Right? But the first one we have to start off with is my previous guest question. I had Sister Letmo Chigudu on as a previous guest in the show. You watched that episode, I know.
Yeah.
She was a nurse. And towards the end of that episode, she asked me, why are doctors nasty to nurses? And I said, well, you can't ask me that question because I'm not a doctor. I only know how to operate. So I said, I'll ask the next doctor that's on the show, why are doctors nasty to nurses? And I'm framing it like that because that's the way she said it. You are welcome to disagree if you don't think doctors are nasty to nurses, or you can maybe give us some insight into why nurses might think doctors are being nasty or whatever. But let me know. Let in.
This is a sensitive topic. Look, I can't generalize. But so, I mean, we work with patients, right? And what we do on ward rounds or whatever scenario it is, right? Obviously, there are some of my colleagues who are a bit, I would say, a bit rude.
Yeah.
And
so
then,
it's not you, it's your colleagues.
Yeah, it's not me.
So,
it's not me.
All right, not you.
So, like, look, some colleagues do take it a bit too far, and they generally are a bit rude and condescending.
And you've never been rude to a colleague or patient?
Not that I know of.
Okay, all right. We'll have to get some colleagues onto the show.
When it's warranted. But what I'm trying to say is, on the other end of the spectrum as well, you get a lot of sisters.
That's nurses, right?
Yeah, so male and female nurses or sisters who are also a bit condescending, and especially if you're a junior doctor.
Okay.
So you give an order and you expect it to be carried out, because that is unfortunately the chain of command. There's hierarchy in the healthcare system.
Okay.
So sometimes you get a junior doctor who's probably like 27, and you get a
junior in what?
So
age or
an intern, a registrar.
Okay.
Remember, age doesn't really matter, because you can be an intern and you could be 50 years old.
Yeah.
So
that's why I asked specifically. That
so hierarchy-wise, right? You get an intern doing a ward round. They give an order. The sister doesn't carry it out, or the nurse doesn't carry it out, right? There are two ways of dealing with that. You can be rude and shout and go off about it, or you can try and educate the nurse in question. And I feel like with the senior doctors, sometimes you expect things to be done because it's in the best interest of a patient. So if I ask, what I find is that if I educate the person that I'm doing around with, the nurse, and I say, this is why I want certain things to be done. Like if we have a patient with a hemothorax, so blood in, a hemothorax, and I say, I want the intercostal drain, which is drain into the chest, I want the output to be measured at a certain time every day. And I will explain and say, this is why it needs to be done and what the importance is. Because I feel like then the sister or the male nurse or female nurse, whoever it is, understands why they're doing it. And if it's not done, then I can take it a step up. But I think when things are not done, it impacts on the patient's care. And that's when people get frustrated. And they either deal with it one way or the other. You can be rude about it or not. And I feel like if a person who generally is quite easygoing and you explain and you level-headed, when you do get angry, and when I mean angry as in you raise your voice slightly, it has a greater impact because the person who's on the other end of it feels like, oh no, I've made a mistake, But if you're someone who shouts all the time and, so essentially there is no reason why nurses find doctors rude or doctors are rude to nurses. I think you can't generalize. And you have to be in the situation. In a high pressure situation, a patient's crashing and you ask for something that if you're not given whatever you ask for within 5 seconds, the patient might die. Then you're going to get shouted at.
So it's teamwork. And what I'm getting is you prefer to communicate and empower as opposed to just barking orders. Because you find that more effective, I guess.
I do, but I also think that the system is such that sometimes junior staff, both nurses and doctors, are placed in high pressure situations where they might be a bit slower than they should. And this leads to tension and arguments and fighting. So if you put a very junior sister in a resus sort of scenario, and they don't know, you ask for an airway, oropharyngeal airway, to keep the mouth open, and they don't know what you're talking about. That person who's leading the resus is going to get angry. And
does that even help though? I mean, you can't really blame the junior.
It doesn't, but I mean, as I said, we're all human.
It's high pressure.
Put yourself in the scenario. You need something or someone's going to die and someone doesn't know what to do or where to get it.
Okay, so to answer Letty's question, Letty, if you're listening, what I'm taking from this is it's like the high stress environment, and the doctors are in the best interest of the patient, sometimes maybe acting out of desperation and lashing out due to pressure. I don't know. Well, maybe I'll ask more doctors as I get them on that question, just to see the various perspectives. Okay, so I've got a Twitter follower named, it's Thegan or Tegan. I'm sorry, I tried 3 times. If I've still slaughtered your name, apologies. But his name does start with the first 4 letters that your name starts with. So that's coincidence.
It wasn't me.
And he asks, do surgeons ever make mistakes while doing surgery?
Yeah, well, at least you're from MPS. So look, To be honest, I don't know how to answer this.
Yeah. Well, you said that doctors are humans. So
look, what do you define as a mistake? Because anatomy is different.
yeah.
Like you learn anatomy, but doesn't mean that everyone has the same anatomy.
Yeah.
So a mistake as in like gross negligence.
No,
patient, you leave a swab in a patient?
Yeah.
Or does a doctor ever do something where it's the wrong call?
Okay.
So what I think is, if you're looking at the trauma setting,
yeah.
It's high pressure,
yeah.
right? And sometimes you do what you think is best for the patient.
Mm-hmm.
And if you're doing damage control, which essentially means you have to stabilize the patient. Someone comes in a trauma setting, they're bleeding, you need to stop the bleeding.
Mm-hmm.
That's the first thing. You stop the bleeding, you get the patient off the table.
Okay.
Now, that isn't an easy concept for people to understand, because it sometimes means leaving the patient's abdomen open.
Yeah.
Right. And for the layperson, they'll think like, why are you leaving the abdomen open? You haven't done anything, you know. But when you look at the theory behind it, you basically stopping the bleeding to get the patient a little more stable, resuscitate them, get them back. So to answer you, sometimes not all decisions work out, and you do get patients who die. Mm-hmm. But I think that no surgeon ever goes in without thinking about what they're doing and without doing what's best for the patient.
Yeah.
The outcome might not be great all the time, and now I'm talking about obviously emergency situations.
Yeah.
Obviously, elective settings are a bit different because if something goes wrong during an elective procedure, the backlash is a bit more.
Okay. So there you go, Twitter follower. What I'm getting from that is that surgeons never make mistakes, and medical malpractice attorneys, you're going to be out of work very soon. Okay, that's Dr. Naidoo's answer to that question. A good segue to the next one, because you mentioned patients dying. My colleague Rotondwa, who's a colleague and friend of mine, and a lawyer, she asks, how did you navigate the first patient that you lost on the table?
Okay, that's a good question.
Can you remember the first patient that you lost?
I actually, and I'm speaking for myself, but
yeah, well,
I'm obviously not the most experienced surgeon. I've only been...
how long have you been a specialist?
Surgeon. Well, I finished my exam in 2021. So
Okay.
I've been board certified surgeon for 3 years.
Okay. Yeah.
So obviously reg time before that, and whatever
in training.
I've done.
So you've trained.
So I've trained before that, but as a registered surgeon, 3 years. So I think maybe I speak for myself, obviously, but for some reason I remember my patients, especially the ones that die on the table, because you never get used to it. It's always shocking. It's a bit more of something that you can handle if it's a trauma setting and the patient comes in already
a hopeless situation,
like not doing well. Yeah. But for the patients who you think are going to do well and you're going to get them off the table and everything is going to be fine and something goes wrong, doesn't necessarily mean it's the surgical aspect of it. Remember, anesthesia also plays a part. The patient's general health also plays a part. You can still have a heart attack on the table. You can still have an embolism, like a clot, those things are a bit shocking. And
so how do you navigate it? How do you handle it? What do you do? Look, who do you speak to?
No one.
Then?
So I think and this is what's wrong. I'm lucky in the sense that my partner is a doctor, so I have someone to talk to. But there really is there's no facilities for. I don't think doctors are really.
Well, I don't know. Well, I'm asking you specifically. What do you do? This is what Rotondo's asking. How do you navigate? What do you do? How did you navigate the first patient? What happened? Did you go and speak to a colleague?
I spoke to essentially my colleague. Remember, during training, you have a lot of registrars that train with you.
Yeah.
So we talk to each other, and then we help each other through it.
Yeah.
And something interesting that I noticed is that for some reason I have a lot of my patients the relatives, which is wrong. I don't think I should be doing it, but I have a lot of them saved on my phone as contacts, and it's silly, but you sort of go through a grieving process with them. Is how I dealt with it. I had a patient that demised on the table, and her mom was obviously contacting me during her hospital stay. Yeah. And when she died, I still had her mom on WhatsApp. Yeah. So obviously the statuses, you can see the statuses. Yeah. And you see the family grieving, and it's the same process for you as well. Yeah. You sort of grieve with them, and you see how they go from sadness, denial, accepting, and you sort of go through the same process. But in other words, we speak to each other in training. So doctors speak to each other. It's not the most ideal situation. But as I said, I was lucky that my partner is a doctor.
But do they not train you guys on this? Like, is there no course on, handling the...
No, I mean, there are courses, not courses really, but you discuss it.
In postgrad, but nothing formal, is what I'm saying.
Not really.
Yeah, it's amazing. It's actually, because nobody thinks of it from that perspective. I don't like to make it seem like, oh, poor doctor, you've lost a patient, because at the end of the day, it's the patient that's died and the family is grieving and all that stuff, but nobody really considers the other end, right? Like, I'm assuming no doctor goes out there to kill a patient, and obviously when the patient dies on your table, especially unexpectedly, it's a lot to process.
Yeah, it is. And I think for anyone who's ever been in the pit or a trauma setting at night, you are so busy and you're so inundated with patients that you don't have time to grieve.
You just got to move on.
Or you don't have time to chat about it. If somebody says, the sister says, there's a patient, a gunshot on the way from wherever, you just carry on, and then they tell you, oh, the patient died en route.
That's bizarre, hey?
And you're like, oh, okay, the patient died en route.
And no counseling?
And in your head, it's like one less patient to see.
Yeah.
If
but
you
no
understand what I'm saying, which is...
They don't...
No.
Wow.
Well, I've never
in your
been
experience,
part of,
but have you ever heard of some places where they offer this kind of service or counseling?
I think it's more about
what, therapy?
The head of your department, maybe. Like
have you heard of places that have this kind of things?
Not really. In South Africa. So I've been exposed to other countries, and I've gone across to the US. They have amazing facilities where you have groups and you can, sort of debrief. Yeah. So that's a big word, debriefing. Okay. We don't have debriefing scenarios here. Or
what are those M&M meetings that I always hear about?
Yeah, so M&Ms...
M&M, just explain for listeners. M&M is what? Morbidity and mortality meetings.
Yeah,
what is that?
It's when the department comes together.
The surgery department.
Yeah, so you can have interdepartmental M&Ms as well, where you get other departments involved. But generally, it's once, well, we used to have it once a week, and you come together as a department and you discuss the cases that were done for the week. Right. So emergency cases, elective cases, mortalities and morbidities. Right. So mortalities obviously are deaths. Yeah. Morbidities are patients who've suffered some sort of injury but haven't died. Yeah, an adverse outcome, but they're still alive, right? So
by no mistake of the surgeon. Yeah, go on.
Yeah, of course. Yeah. So those morbidities and mortalities are meant to be a teaching exercise. Okay. So you discuss what was done with the heads of the units, the registrars, and then the MOs and the interns, and to try and figure out where you might have done better, where the treatment could have been better or worse, and then look at in some places it becomes a bit of a stressful environment because the registrar presents, and then you also get questioned.
That's the surgeon in training.
Yeah, so you also get questioned, and you have to back up why you did something. Okay. And sometimes it can be a bit scary because you have some of the senior consultants who are quite intimidating, and people have differing opinions. It doesn't mean that every patient is treated the same way. So, but those are our teaching exercises, but they're not meant to debrief. You don't, you discuss the mortality, you discuss why it happened, where you could have done something differently, but you don't debrief.
It's more like a crash scene investigation as opposed to therapeutic or like exercise for the surgeon. So
it's not therapeutic at all. So it's quite stressful.
It's the opposite. Sheesh.
Yeah.
Maybe there's a gap in the market. I don't know, or some sort of, because we always talk about burnout and clinician stress and working under pressure. And to me, as a layperson, I would think that kind of thing would be a basic option that should be readily available.
Yeah.
But I guess we could speak for everyone that, I mean, let's leave it at that for now, right?
Mm-hmm.
The next question from the viewer or one of our listeners. Actually, this comes from Letty. How do you prepare yourself mentally before a surgery?
Yeah, that's also a good one. So, when I was in training, I always thought that once you become a consultant, so consultant and attending, once you are a surgeon, board certified, that suddenly everything, all your anxieties disappear.
Okay.
But I don't know I can't speak for anyone else, but for myself, anxiety never goes away.
Okay.
Because a surgery entails cutting into someone's body. It's someone's parent, it's someone's brother. So I wouldn't say anxiety ever goes away, but I think your level of preparedness and your ability to deal with the unknown is better. So as I said, anatomy is never different, right? Anatomy is never the same. It's always different in each patient. But when you are at a level where you are now an attending, a consultant, you can deal with things that you didn't expect better. So in order to answer your question, I think I'm always anxious, but I prepare by thinking about the procedure. So if you look at the elective procedures, the night before, I always play the procedure in my head and think of every scenario that could pop up.
Okay.
Could there be aberrant anatomy, meaning the anatomy is different, What's my situation going to be like if I find myself in that position? Do I have the instruments? Do I have the material? Do I have the staff available? And a plan.
Okay.
For the emergency procedures, look, it's an emergency.
Yeah.
So you go in, you hope that, for the best, and that's about it. But something as simple as an appendix.
Yeah.
And everyone always makes fun of an appendix, but it can...
What do you mean everybody makes fun of an appendix?
Like when you're a junior registrar, or, you learn by doing cases like an appendicectomy, and everyone thinks, the appendix will pop up and you just see it there.
Okay.
But
if you say so.
Many a medical officer has called a consultant out at night because they can't find the appendix. So something as supposedly insignificant as an appendicitis can kill a patient.
Okay.
So
you visualize, you plan, you think ahead. Can't you guys get like some PlayStation game or something where you just simulator?
Can. So that's for you get a lot of simulators now, especially for minimally invasive surgery.
Where do you get them?
So you can order them online. You also get reps who even make the boxes for you.
What?
So
what do you mean? What does it look like? Is it like a physical thing?
So it's a box. It's in the shape of an abdomen.
Yeah.
And you get instruments and you attach it to a screen. You can attach it to your TV. You can attach it to
iPad or
an iPad, the computer.
Sure.
And then you practice. And then you also get PlayStation games as well that help you simulate.
That's amazing. How much do these things go for?
Timu is a thing now, so you can get it for... Look, it used to be very, very expensive, but now you can get it for like less than 1,000 rand.
What? That's ridiculous.
So something cool. I see a lot of surgeons, especially from abroad, who have been teaching their children. So you get like 9-year-olds, 10-year-olds who are so dexterous and can basically do laparoscopy better than some seniors.
Wow.
Because they just practice on these.
Okay, so maybe you must buy more of those things then, so you don't have to just think about it in the head. Okay. Next question comes from Gives12 on YouTube. How do you manage to recover from big losses / failures? I think you've already answered. I don't know. Well, you answer now.
Well, depends on what you consider a failure.
Yeah.
There's academia, there's the actual surgical aspect of it. And it's a good question because it's depressing. Yeah. So if something if you do a colostomy, which is basically bringing the intestine out onto the skin, right?
Okay, why would you do that?
Well, say a patient has an obstruction, or in the trauma setting, the patient has a gunshot and it's damaged the intestines. So say you've done a colostomy and it retracts, which means it pulls back into the abdomen, or it becomes necrotic, which means it dies. That's a failure, right? And then it's depressing because you did something and it didn't work out, and then you'll be depressed. Well, so how I think about it is it depresses me for a long. It always comes back to haunt me.
Okay. Every now and then you'll think about it.
Yeah, and then it ruins your couple of hours. And
I think you guys need therapy or something, man. Jeez, this is not nice. I don't want to be a surgeon after hearing all this.
No, but it's part of the job.
Yeah, I guess.
So it's one of those things, and it makes you learn from your mistakes, because you'll go back and you'll think, why did that stoma retract?
Yeah.
You'll go through it, and and you get a thick skin, because you might get some comments from a senior to say, oh, yeah, your stoma retracted.
Okay, that's a nice senior. Those are nice people. You got to, it's important to remember that even the smallest of comments can have a big impact on somebody, right?
Yeah, but it's the truth, and you're not going to sugarcoat it.
So what do? You just think about it, you deal with it, and you move on. Sounds great.
Yeah, and you try and figure out why you did what you did and what went wrong.
Wow. Okay. Well, on this theme or this feeling that I'm getting of like, I really would not want to be a surgeon hearing all this stuff. Here's a good question from a Twitter follower. It's from my good friend, Dr. Roketwa Rocky Sididza, who was studying medicine at Tux when I was in undergrad. And he coined the phrase, studying is for cowards, because when me and my friends would say, we're not coming out with you, Rocky, we're studying. He'd say, studying is for cowards, just go and write, you'll figure it out. So I got to have him on the show. But here's a question. Money aside, do you enjoy your discipline? This is because I am yet to meet a cheerful surgeon. Yes, so?
Well, yeah.
Nice question, Rocky. Yeah.
Yeah, well, look, I do. I love my discipline. I would...
What is there to enjoy?
Not trade it for anything, but I must say that I made the decision in my head to do surgery very long ago.
Okay.
I was an intern. It was my second rotation, and I just loved surgery.
Yeah.
And I think it's because
what do you love about
you work as a team.
Okay.
I did my internship in RK Khan, and
RK Khan.
Yeah, in Durban. So I had amazing registrars. We had a very awesome team. Okay. And exactly how it is in Scrubs is how I felt.
Scrubs, that's
like
that comedy
the TV show. Yeah. So exactly how it is in Scrubs, when you see the surgeons walk into the ward.
Cool people.
It's just, you are there as a team, you sort the patient out, you have a plan. It sounds silly, but so my registrar at the time was a friend of yours, Sandhir, Dr. Maraj.
Sandhir, Dr. Maraj.
Yeah, it was awesome. We had the way we worked. You work hard and the rewards are amazing.
Okay.
So
like what?
A patient has, I always use the same thing, like examples, but say a patient has an abscess, something supposedly insignificant.
Yeah. And in RK Khan, they call it an absa. Yeah.
So an absa.
Yeah.
So, and
that's
then,
a Durban joke, by the way.
Yeah, so the auntie comes, she has an abscess, and then it's really painful. Yeah. And she can't lower her arm because it's so painful. You can't lift it. You take it to theater, you drain that abscess, and fountain of pus comes out. Okay. And the next day the patient's go home. So for me, the allure of surgery was, first of all, the camaraderie in the team, because you all struggle together.
Right.
So the intern is struggling because you've been there for over 24 hours. Okay. The registrar is struggling because they've been there for 36 hours.
Yes.
And they have to deal with the consultant coming on. You wait for the consultant to come. The round only starts at 2 p.m. You have to do the post-ward round, work. And then you all leave together. You're all tired together. You stress together. It was really cool. And so what I'm saying is I made my decision to do surgery very early on. And everything after that I did in order to get to that point.
Okay.
So my choices that I made in terms of where I went for ComServe, where I did MO time, and then where I chose to do reg time.
Okay.
It was a very planned out.
So teamwork, so Rocky. Dr. Naidoo likes what she does. She loves it because of teamwork and helping patients, like properly. It's not like some of these things where you prescribe something and then the patient says, "Oh, it would have gone away anyway."
No, I'm not saying it's.
I know. I'm
not saying it's easy.
Yeah, it doesn't sound easy. Trust
for
me.
anyone who's contemplating going into surgery, there are going to be many times along the road where you're going to say, "This is. I feel like quitting."
Okay.
As you said, when a patient dies, or when it's just too stressful.
Yeah.
Because remember, you're not just confined to the ward.
Yeah.
You're confined to not one aspect. You do ward rounds. You have ward patients. You have theater. Theater is a big part, and theater itself has its own stresses because you have to learn to deal with other people.
Okay.
Theater is a completely different environment. So
surgery.
It's not easy.
Surgery sounds a lot like. I used to be a lawyer and I used to be in the litigation department. It sounds a lot like litigation because there's also teamwork, high pressure, high stress, good rewards. But with litigation, my boss said, "Don't come work for me if you want to make money." Now, Rocky said, "Money aside." So I'm assuming he's implying that there's good money. Is it good money? There's easier ways to make money.
There are definitely easier ways to make money.
It's okay to say if you're doing well. I mean,
look, everyone knows the situation, South African situation where you have public and private.
Okay.
Well, you have public and private. So I would say in public, the rewards are obviously there.
Yeah.
But financially, it can be a bit constraining.
Yeah.
But if you're an academic, it's a lot more rewarding to be part of the public system because you can still, especially if you're in an academic setting, with a university adjoined to it, so you can still be part of academia, right? Private is lucrative, yes, but general surgery isn't the easiest way to make a lot of money. You can, but you need to work hard. There are a lot easier, I would say easier, but no discipline is easy because you have to get there. But there are a lot less time-consuming specialities where you can make money, a lot more money, a lot easier, and with less hours involved.
Okay, cool. Last question from a viewer/listener. This one's from Morgany in Cape Town, our connection. We touched on it a bit earlier, and she asks, how do you put your heart aside and continue with what is expected? I think this is in the context of like difficult patient interactions, difficult cases, where you are seeing this patient in a bad situation. How do you separate?
I think sometimes it's good to not separate it.
Okay.
In certain scenarios, you have to be human because you have to treat a patient. You have to have empathy. And I think having empathy makes you make good decisions in certain scenarios. Because if you go by the book, patients don't come according to a guideline. Every patient is different. So I think that it's something you learn with time. As an intern, you see a lot of interns cry when someone dies and they leave the room or they have
you ever
little
cried?
Mini breakdowns. Not really, not me.
Sure. Okay.
I'm not saying that's a good thing.
Yeah, I didn't see that. I'm just.
But I think it also.
Just judging you. That's all. No. Yeah.
I think that also has to do with where you go in terms of what discipline you do.
Okay.
And I am generalizing here, but I felt like from what I've seen over the years, a lot of softer interns, went into certain specialities, and certain interns went the other way. But you do get better with time. You do get better with time.
Yeah.
So you get better at dealing with death and with strife and difficulties and difficult patients.
Yeah, I mean, we all know surgeons are well known for their softness and their empathy and their caring nature. I say very sarcastically because I know lots of doctors that feel otherwise.
This is interesting because it also lends to the topic of females in surgery.
Yeah.
Because I think a lot of people believe that to be a surgeon, you need to be that loud, barking type of person.
Right.
Who shouts at everyone.
Yeah.
And when I was an intern, there were a lot of females who came into surgery. There weren't a lot of females in surgery, but the females who were in surgery, which weren't many, felt like they had to be that sort of personality, even if it was against their nature. Obviously, you do get females who are aggressive and loud, and that's their personality. But those who weren't felt like they had to be. And if they weren't, they were lost in the crowd. But things are changing. So the typical...
I know lots of women surgeons, Like now. Isn't that is it more?
The numbers have increased drastically. And a lot of people will say it's because people in higher positions were forced to take females on because of the
diversity and inclusion.
Pushback and so you see the US is very far ahead of us still, but the number of females in surgery now is still a lot more than say 10 years ago.
I mean, I know quite a few women in surgery. How do we get to that point? Okay, we were talking about how do you put your heart aside. Okay, so you say you think empathy, sometimes you got to keep your heart in it sometimes. But sometimes you've got to keep your heart out of it.
Sometimes being empathetic and being the patient's friend is not good for the patient because they tend to think of you as a friend and not as their treating doctor. So sometimes you need to put your foot down and say, I'm the doctor. This is what I think is good for you. And
obviously, they make the decision at the end of the day.
At the end of the day,
be assertive.
Yeah, but you have to be able to make a decision and stick by it. You can't be, you
can't waffle and
because that's not making a decision. So Mogni, I think it comes with time and experience.
Okay, so what do you call a doctor who couldn't get into med school?
Me.
Huh? Okay, well, I was gonna actually the joke is, and a lot of medical doctors use this joke with me. It's, what do you call a doctor who couldn't get into med school? You call him a dentist, right? So I thought you were going to say dentist, and then I was going to say to you, that's rich of you to say because you couldn't get into med school.
Well, I spoiled your joke.
Right, so you spoiled it, but the point I wanted to make is you couldn't get into med school. So take us all the way back, before you even go to med school. Where are you born? Where are you from? What do you do? All that stuff. Oh, I mean, how was your upbringing? All those things.
So I was born on Earth, but...
Oh, well done.
I was born in Durban, so I'm a Durbanite.
Durban, right? Where about in Durban?
In Tongaat.
Okay.
I was born in St. Augustine's, I think.
Oh, is it? Okay, so that's proper Durban.
Oh, no, I was born in St. Aidan's.
All right.
I always mix the two up, but St. Aidan's. So I was born in Durban. I was raised in Durban. I went to school in Durban. And then...
Were you good at school? What was it?
So look, okay, so you want detail. Okay, so look, I was a good student. I was always an A student. And I always, look, from an early age, I knew I wanted to do medicine.
Why?
I don't know, actually. It's odd. Our family has a lot of doctors. So a lot of our older cousins were doing medicine. And a lot of people tell me that I copied my cousin. You want to be like your cousin. And incidentally, she's also a surgeon. But she's 9 years older than me. So, but for some reason, I don't know if I watched a program on TV.
Scrubs.
No. I was very small. So from like forever, I always knew that I wanted to be a doctor. And I had to try and...
What do you mean?
So like...
I thought you were alluding to your height because... You know what? I think you might actually be the shortest surgeon in South Africa.
I doubt it.
Oh, do you know somebody shorter than you that's a surgeon?
No, not really,
because
but I doubt.
For the viewers, okay, you can't even see it even though if you're watching this. Dr. Naidoo is very short. Also, we haven't mentioned that she's my sister, like my biological sister. So if you think that I'm being very crass and judgmental in this interview, you're right, because that's just how we operate. So please don't think I'm going to be like this if you're a potential guest. I really will not make these sorts of comments. But I think you might be the shortest surgeon in South Africa. But anyway, let's go back.
So what were we talking about?
We're talking about how you decided to do medicine. You don't know why.
I don't know why. And you can ask the dad or mom. But like, I always said I wanted to be a doctor. And I tried to convince myself otherwise. So in grade 10, then I said, no, I want to be a game ranger. So And I thought, yeah, game ranger and whatnot. But I always knew I wanted to do medicine. And I did. I mean, I think I was, as I said, I was an A student.
Yeah.
I was also very good in sports. I was a really good swimmer. I played first team tennis, first team netball, all the way through high school, matric. But I also, I wouldn't say I wasn't a science person.
Yeah.
I didn't like maths. I didn't like physics. And at the time, a lot of people laughed at me because I did French and I did art and drama, and I did art and drama, 2 separate subjects. So as my 6th and 7th subjects in matric.
Okay.
And in retrospect, a lot of people, you know, are like, why did you do that? Like, why are you choosing those subjects?
Yeah.
And coming full circle, I feel like it has really added to my experience and to my profession, because as a surgeon, I feel like surgery is an art.
Okay.
And art and drama really taught me to be analytical.
Okay.
You analyze works of art, the art history that you study. You put up an exhibition, teaches you time management, and the speech and drama aspect of it has helped me communicate better with colleagues, patients, and also I think it expands your mind.
So
and
so
I did all of that.
You still don't know why you did medicine, okay?
No,
so it's
and
just,
so I didn't get into medicine.
Yeah.
And it made me
that's how we got
angry
you.
for a long
Why
time.
didn't you get, didn't you do well? Didn't you get lots of A's in matric or something? Not really.
Look, I did, but it wasn't enough. You have to be, you have to get 98%, or I don't know what it is now. I've been out of school for a long time.
Yeah.
But also,
I was literally that guy that became a dentist because I couldn't get into med school. So I know this, and I had straight A's in matric, right? So you didn't get enough. You didn't make the cut.
Yeah.
But you still...
I still wanted to do it.
So what did you do?
Yeah. So, well, as I was saying, I was angry for a long time about that, because I felt like I did everything that warranted getting into medicine.
Okay.
And for various reasons, you know, as you grow up, you mature and you realize there's a reason why everything happens.
A reason. Yeah.
So I did pharmacy.
Okay, so you did pharmacy.
For 2 years at Wits.
What was the goal there?
I just chose it. I wasn't interested in it really.
So you weren't planning to do it as a stepping stone to medicine or something?
It was an option. It wasn't an easy way to get in, because you have to, there are GEM programs, so graduate entry medical programs, where you can sort of segue into medicine. I know Wits offers it.
Yeah.
But I just chose something that I thought would be something that I might like.
Okay, so you were thinking you might be a pharmacist.
Yeah.
Sure. So you gave up on the dream of medicine?
Not really. As I said, I still tried. I applied to universities again after first year of pharmacy.
Okay.
And I got an interview, and the interview went very badly.
Where?
It was at Walter Sisulu.
Okay, so that's in the Eastern Cape.
Yeah, so the panelists were very, I wouldn't say, they were rude.
Okay.
So, you know, they asked me, you know, why didn't you apply the year before? Because you did well. And then I said I did. So it was a bit of a, you know, weird interview.
Right.
But I didn't get a place.
Yeah.
So then the option arose where we knew someone who had gone abroad.
Okay.
Someone who was actually at school with me.
Yeah.
A year older than me.
Yeah.
And he was in Mauritius.
Okay.
So...
But hold on, you're skipping something. I know this because I'm your brother, but what happened with pharmacy?
Oh, I didn't study.
What?
So I didn't really take it seriously.
Yeah.
I wasn't...
So you went
I wasn't really happy. I wasn't really interested.
You went Wits University, and then you were having too much fun, and then you failed.
Second year.
Yeah, second year. And you got excluded.
Yeah, I did.
And
so... Yeah. I mean, look, I wasn't happy with the way I was in terms of what I was doing. I didn't find it interesting. The same thing with first year. I just went to class, had fun. Yeah. And, you know, first year was funny because I didn't sup anything. I just passed everything. Yeah. And second year came around, I thought, it's going to be the same thing. Just chill, do whatever. And really wasn't interested in pharmacy.
Hits you hard, yeah. Okay, good. I think it's important to mention these things because failures are also important in life and
Yeah,
good to
I
mention,
agree
I
with
feel.
you.
So that's why I didn't want to skim over it.
Oh,
So
yeah. So look, I also thought about it, and it was a very important aspect of my growth.
Yeah.
Because you mentioned, did I give up on what I was doing or my dream of being a doctor or whatever?
Yeah.
I think what's important to mention is I still went to the dean's office quite often, because I would,
At Wits.
yeah, I would see a lot of people in the pharmacy class getting places, because there's a waiting list. So when people drop out,
places for what?
For medicine.
Okay.
You get the call and, someone dropped out, so you can come do medicine. So I went to the dean's office and I had a chat with the secretary. And she said something to me, which I will never forget. And she's like, you don't always get what you want in life.
Okay.
And I was like, okay.
Yeah.
And it just stuck with me. Yeah. So second year, it was fun, but
then it ended up in not working out. So you got excluded from Wits, right?
Yeah.
Then you hear about this opportunity to study abroad.
Yeah.
Abroad being?
Mauritius.
Right.
So as I said, we knew someone who studied there.
Yeah.
And they were very happy. And so we looked at the syllabus, we looked at the curriculum, and went for the interview.
Yeah.
And got the call that I got a place.
Where did you interview? In Mauritius?
So it was in Durban.
Okay.
So the interview, got a call like a few days later, and then left.
Left when?
Within like a week. No, I think it was like two weeks.
Wow, that escalated quickly.
We went in January. But maybe I'm remembering it wrong.
That's fine.
Because it felt like to me very soon.
Yeah.
But not more than a month.
Okay, so so you go to Mauritius, and my first guest was Yak Lindy. He studied at the same university, so he's given us a flavor of that. It's a very strict India-run facility, run by Indians, and very strict. And there's no opportunity to do what you did in Wits there. You got to go wear a uniform, I remember.
Yeah, so you wear a uniform. There's a roll call. Varsity is from Monday to Saturday.
Wow.
Yeah. Okay. And it's a different syllabus. So
military.
It's very, very militant.
Yeah, militaristic.
But it was a good experience. Yeah. And then I made a lot of friends.
Okay.
Who are now in different parts of the world. So it was quite awesome. But it was difficult.
Okay.
And the syllabus was quite demanding.
Yeah.
So you either sank or swam.
I'll never forget they used to make you draw anatomy, like for anatomy.
Yeah, so you had to draw. So you would do a system every 2 weeks or 3 weeks. And then you would have to draw the anatomy. You had a logbook, draw a label. And then you get tested on that. And I mean, that's added to
I don't think they do that in South Africa, any of the South African universities.
I don't think so. Being in academia, like as a registrar, I don't remember the interns ever having the students ever having to do that. But it was quite intense. And that's part of your dissection hall. So when you're doing anatomy and dissection hall.
So how many years is this degree now?
It's 5 years.
5 years, and
so it's 5 years. You don't do. So in South Africa, you do a first year of physics, biology.
Yeah.
So that is the equivalent of. So in Mauritius, the Mauritians themselves are. They do the UK syllabus for matric. They do A levels.
Right.
So they don't. The syllabus there doesn't entail physics and biology as first year.
Okay, so it's 5 years.
Undergrad.
But do you know that when you come back now, you're going to just jump in and become a doctor? Or what was the plan? Were you going to
So I knew, obviously you don't do anything without research. So I knew that I had to write a board exam.
Okay.
And I prepared for that.
So you were planning to go to Mauritius and come back and be a doctor here in South Africa?
Yeah.
That was always the plan?
That was my plan.
Yeah.
A lot of people didn't come back.
Yeah.
They went to the UK and to the US. But I wanted to come back here.
So you knew that you're going to have to write this board exam.
Yeah. And then I planned for it. Yeah. So I had known a lot of people who had written before me. And also, as I said, a lot of our cousins are in medicine. So they were already consultants. And a lot of their registrars that they interacted with obviously gave them feedback, and they had quite a few people who had written the board exam, and I got information from them, and I used a lot of the South African university's material to prepare for the board exam.
So wait, so you come back after you've got your degree, and then you're not allowed to practice here. You have to wait for an exam.
You have to write. So as with any country, you have to write an entrance exam.
Okay.
So when you go to the US, you write the USMLE. Go to the UK, you write PLAB. So in South Africa, you write a board exam.
Yeah, the HPCSA board exam.
Yeah, which is an entry level.
So how long did you sit here doing nothing before that exam?
Well, it wasn't nothing. I studied.
Oh, well, yeah, not practicing, I mean, yeah.
So I came back in December. I wrote in Feb and April, because there are two parts, a theory and a practical.
Yeah.
And then I think I did the practical in UP.
Pretoria.
Yeah. So I stayed with you, I think.
Okay.
And then the practical, and then I started work in June.
Okay, so you started practicing 6 months after you came back to South Africa.
Yeah.
And then what do? You do internship?
Yeah, so internship, ComServe, and then I went into MO time, so which is medical officer time.
2 years of internship, 1 year of community service that you did at Standerton Hospital. The internship you did at RK Khan.
Yeah. So that's 2 years in Chatsworth.
In Chatsworth, Durban.
Yeah.
And then after that, what happens?
So I wanted to, as I said, I wanted to do surgery.
Yeah. When did you discover this?
So as an intern.
At RK Khan?
Yeah.
Okay.
So I did.
Working with Sandeer Bhai and company.
Yeah. So I applied for MO time. So MO time is a medical officer, because I had heard that Kimberley had a very good surgical department.
Kimberley in the Northern Cape.
Yeah.
Right.
So I applied for an MO post there and I got it. I was lucky. I got it. So I didn't have any lag in. I didn't waste any time not working in between ComServe and MO time, because now it's quite difficult to get public jobs.
Okay.
Because for a lot of reasons.
Right.
But I was lucky. I got a post.
Yeah.
And I went to Kimberley, and that was
from Durban to Kimberley. No, from Standerton to Kimberley.
Yeah. So I worked in quite a few provinces.
Yeah.
Mpumalanga, KZN, the Northern Cape, and
Mauritius.
And then Reg time was Gauteng,
KZN.
And then you also rotate in the Northwest, because I was at SMU.
This thing takes you a lot of places in the country, this studying thing. I mean, I guess a lot of people have to go through this. It's probably not unique to you, except for the Mauritius part.
Yeah.
But if you're going to be planning on specializing, you might need to...
You have to be flexible. So if you want to wait for a post in Cape Town, for example, or KZN, and you're not getting it and it's full, you might wait 10 years.
Okay.
But something might pop up somewhere else and then you have to move.
Okay, so Kimberley?
So Kimberley was quite a great opportunity. It was the best decision I made, I think, because the department is run by Dr. Byatt. And
who's Dr. Byatt?
Dr. Byatt's a general surgeon. So, and then there were 3 other consultants at the time. So Dr. Kimi, who was when I got there, he had just finished his training.
These
so
are
he was
specialist
a newly minted surgical consultant. So he was still very theory orientated.
Okay.
So we learned a lot from him. And then Dr. Blanco and Dr. Dutoy. Okay. So amazing consultants.
3 surgeon specialists.
4.
And
then Dr. Dutoy is now a vascular surgeon.
Okay.
Dr. Blanco, one of the most amazing surgical talents I think I've ever come across. He can do anything.
Yeah.
And Dr. Byatt was amazing and is amazing. He's still in Kimberley, still running the department. Actually, a few weeks ago, I was talking to a colleague and we were trying to figure out how many surgeons Dr. Byatt have come through Dr. Byatt, and it's just
that's amazing.
Amazing. Yeah. So I think that was a very great decision to have made, was to go through Kimberley, because I learned technical skills in Kimberley.
That was a good decision, because also you're not specializing there, right?
Yeah.
You basically, it's a part 2 specialization, right?
Yeah.
And then how does it work? Do you have to be an MO in a certain amount, for a certain amount of time before you can become a specialist, or what was the plan there? I don't.
So I just
Explain that to
wanted
me.
skill, right?
Okay.
And I didn't realize at the time that in order to get into a registrar post, you had to have independent practice.
What do you mean? Okay,
And
independent practice registration with
yes,
the
with the
HPCSA.
HPCSA. And at that time, the HPCSA did not allow you to register as an independent practitioner if you hadn't written another exam.
We're talking about as a foreign qualified doctor.
So foreign qualified doctors back then had to write a second exam.
Okay.
In order to get independent practice.
Right.
Which didn't really make sense to me.
Yeah.
Because you needed independent practice to work in private.
Okay.
In the private sector.
Yeah.
But to work in the public sector, you didn't need that.
Okay.
So as a foreign qualified practitioner, you could work in public and treat public patients, but you were not allowed to work in private.
Yes.
Or to specialize, which was quite difficult to understand.
Yeah.
So obviously, once I looked at applications for registrarship, I realized that I didn't have that independent practice.
Right.
So either way, I was going to do
when did
MO
you start
time.
looking to specialize?
When I started medical officer time.
Okay.
So in that first year, I realized that
there's this requirement.
And I was very against writing another exam.
Yes.
That didn't really make sense to me. So that's when I approached quite a few people.
Yeah.
But eventually, your boss, Maria Philippides, was very instrumental in helping.
Yeah, you came to us, and then we helped fight your regulator and get you that registration, basically.
Yeah. But essentially, I spent 3 years as a medical officer, which I don't think was wasted time. Because when I started Reg time, I felt like I didn't behave like I was, but I felt like I was equivalent to a mid-level registrar because of all the surgical techniques and skills that I, had amassed in Kimberley.
So it was a good move going to Kimberley, and then maybe that if anybody's planning on becoming a surgeon, they must think of going to Kimberley.
Yeah, I always tell people it's if you want to, it's the best place to go to.
Okay.
One of the best.
And then you get into, after the MO time, you get into Sefako Makgato University.
So no, after MO time, well, not after, you can do MO time for as long as you want, but I decided to come to Joburg. So I actually came to Helen Joseph as a medical officer.
Right.
And then I applied for a registrar post, got in, started Reg time in the Wit circuit.
Yeah.
And then I transferred over to Sefako Makgato.
Okay.
And I had my own reasons for that. I wanted to work with Prof. Koto.
Prof. Koto, okay.
So Prof. Koto is basically the president of the College of Surgery.
Yeah.
Now, but back then, Prof. Koto was well known for being very forward thinking with regards to minimally invasive surgery.
Okay.
So laparoscopy. And I really wanted to be in Sefako Makgato. It wasn't easy though.
Kefis was very, singing Prof. Koto's praises.
Yeah, he's amazing. He's pioneering minimally invasive surgery.
Okay.
And in South Africa, which is a third world country.
Developing country.
Yeah. Well, he gets a lot of pushback.
Okay.
So he fights. He has fought many battles, but it's at a point where laparoscopy, minimally invasive surgery, is now very, very popular in South Africa. And if you are a young, upcoming surgeon, you can't really go forward without knowing how to do minimally invasive surgery. And he really was a pioneer.
Okay.
And even
is
before
he still practicing or operating?
So he's still the head of SMU, Sefako Makgato. He's also the president of the College of Surgery.
Okay.
So when I got that post, obviously it was quite difficult to now ask the bosses or to tell at WITS to tell them, look, I'm leaving.
Okay.
And I want to transfer across.
That's a bit awkward.
It was the most awkward month probably of my life.
Yeah.
But for my career, it was something that I had to do.
Yeah.
So I transferred over to SMU, and then that's where I did my surgery training.
Okay. For how many years? That's 4 years, right?
Yeah, it's 4 plus 1. So plus some people have a clause plus 1, so 5 years. So you do surgery, your surgical training, and you do a master's in medicine, general surgery. So I did my master's and I did my surgical training at SMU.
And these are all just basic requirements to become a specialist surgeon.
Yeah. So I was there for 4 years. So then I decided, so look, as I said, Kimberly was very instrumental in preparing me because I knew also that I needed to do a master's. And I formulated with Dr. Kimmy was very helpful. I formulated an idea of what my master's could be when I was in Kimberley.
Right.
And this was something that helped me finish my master's in like 2.5 years. So by the time I finished, I wrote just after 36 months, I finished and I resigned at 4 years. So you need 48 months of training to register with the HPCSA as a surgeon. So my paperwork was all done.
And then what do you do after that, after specializing?
So I took some time off just to figure out what I wanted to do. So I didn't know whether I wanted to go directly into subspecialization or if I wanted to stay on and do a little more time because my contract was so because I didn't really know what I wanted to do.
Why do I not remember this? But anyway,
I think a lot of people feel this way. So you can go one of two ways. Like you can just continue down the academia route, and because after you finish, there's like a dip because you prepare for this exam for 4 to 5 years of your life, and you always like it's adrenaline, and then you write, you finish, and then you don't know what to do.
So how long was you on the sabbatical?
4 months.
Where does money come from? Like,
so I planned for it.
Oh, okay. You plan and you save.
Yeah, I planned for it. So then I got a call from Prof. Saying that he had that he had a consultant post at SMU, and I was even looking at what the options were: private, public, subspec, and then he said he had a post. So I decided, okay, let me go back because there were a lot of things that I still wanted to do, especially research-wise. So after doing the MMed, I really enjoyed research and I wanted to operate. So went back to SMU, did quite a lot. That's where I also continued the research route. I presented my research. I won the Seals Antrobus Prize, was sent to the US to present.
Yeah, you mentioned the US. I was going to get to that. Okay.
Yeah, so that was awesome.
Well, let's talk about that later, but I want to hear about now this. So you go, you 4 months, you're not working, then you go back.
Yeah.
Luckily, you save money. You go and so you're working in the public sector at SMU, Sefako Makgato University, as a specialist surgeon.
So I got a consultant post and I worked in the breast unit. So I was there under Prof. Mukoni as the junior consultant. So I worked there from 2022 to 2024. So 2 years.
Why that unit? Do you pick it? Or?
Well, Prof said he had an opening there. And I was interested in it as well. Breast surgery was interesting. And I knew that there was a need. So Prof. Mukoni didn't have a junior consultant, and I thought I could help her out, provide a service, because the breast clinic was one of the busiest clinics. And
what do you do there?
So breast surgery patients, so any breast disease patient, not everyone always thinks of cancer, but any breast disease. And then they also had a very long backlog of patients waiting for surgical intervention. So it made sense for there to be more than one consultant in the unit. And also when you're on call for general surgery. And trauma. So I still got a chance to do my general surgery and trauma. And on top of that, learn a bit more. So the unit also gave chemotherapy, which is the only unit in the country to give physician-administered chemo, for surgeon-administered chemotherapy.
Wow.
So it is a skill that I definitely, was lucky to
be exposed
to experience, because Prof started that herself. And because there is no oncologist at SMU. And it's interesting because George Mukhari Hospital is the second largest hospital in Africa.
Yeah.
Second only to Bara.
And wow. And there's no
and yet
oncologist.
There's no oncologist
Still,
there.
now. Wow.
So, well, I think they now have a medical oncologist, but he doesn't have staff. So there's not much he can do. So that was definitely something awesome to have done. And
tell me about the US now. What was this prize that you won?
So I presented my research at the...
What was your research about?
Yeah, so I presented so there's an annual conference where all registrars and consultants, whoever, get to present research that they've done. So a lot of registrars do present their MMeds. So my MMed, obviously, which was...
That's your master's in medicine, right?
Yeah,
MMed,
which was done. Yeah. Was on delays in newly diagnosed breast cancer patients. At 2 institutes. So I used George Mukhari and I used Robert Mangalisha Subukwe Hospital, which is Kimberley. So I compared the two to look at what the delays were. And the delays were vast. So I presented this at the SRS, which is the Southern African Research Society. I presented it there, and then I won a prize. I won the prize, which was it's called the Seals Antrobus Breast Cancer Research Award. And they sent me to America to present my research. So which was cool because it was the American Surgical Congress. And that year I went in 2023. So that was in Texas. So I went to Texas.
Cool.
And I had a mentor there and someone who introduced me to a lot of different surgeons in the field, ranging from like pediatric surgery, general surgery, endocrine. And then it's a huge conference, a national conference. So you also get surgeons from all over the US.
Cool.
And a lot of surgeons from Colombia, to many different countries. So it was really awesome because I got to present and I represented South Africa, and then you interact and people can ask you questions on your research. So a lot of them didn't realize that we had such great delays. But then our issues were different. The US was dealing with gun law issues, which then bled into issues with doctors because they wanted doctors to become more vocal. And you never ever bring politics into medicine, right? It shouldn't be that way. But they just had very different issues to deal with. And there obviously their abortion laws, which they were quite amazed to hear that our abortion laws were a lot more tenable than theirs. So it was really cool. And I've made good contacts. So that was awesome.
Then 2024, you said that's when you stopped in public. What happened then?
So I always wanted to subspecialize, but I felt like, look, you know, when you get into academia, you never stop. And then it's a slippery slope because you want to do the next thing. You want to do the next project and you want to subspecialize, and then subspecializing leads to something else, and other aspects of your life sort of fall away. And I've seen it happen to a lot of people. So I had to decide, am I going to go straight into subspec or am I going to look at something different? And I decided, let me just take a step back and look at something that I haven't, been into before. I've never done private. And also at that time, sort of worked out because mom was not well and gave me a lot more time to be more flexible with my schedule. So I decided to look at private, and it's been awesome.
No regrets.
No, and I don't say that I'm not going to go back to looking at studying again.
Where are you?
Subspecializing.
Private.
So I'm in the Northern Cape.
Where's that?
So I went back. I went back to the Northern Cape.
Not Kimberley this time.
No, not Kimberley. But I'm lucky enough to work with Dr. Byett. I call him quite often because he's still in Kimberley.
So where are you?
So I'm in Kathu.
Kathu.
And that's about 5 hours from Kimberley. So the Northern Cape is the biggest province in South Africa.
Right.
So, and population is vastly spread out. So I think I'm in Kathu, but the closest basically we deal with 200 kilometers radius of patients.
Okay.
Because they don't have access to a private facility.
Right.
So it's very rewarding.
Okay.
And it's cool. I'm enjoying it. I don't have any regrets. I obviously do miss academia.
I heard there's an airport there that closes.
Yeah,
like in
so
December,
it's a mining town.
holidays.
It's a mining town. So Anglo-American built and funded the airport.
Okay.
So obviously the Anglo-American executives and mining execs and all of them, they essentially closed the airport down.
Wow.
So I've been told.
Sure.
Between the 16th of December to January.
I'm just trying to give the listeners and the viewers like a sense of, it's quite a small town, but at least it has an airport. I mean, you worked in places that...
Look, it's a small town, but for anyone who's worked in a mining town, I mean, the mine employs over 70,000 people.
Okay.
So it's small in the sense that maybe people don't know about it. Area-wise, it's small, but it is a very bustling town. Like it's busy, and I'm busy.
Okay.
So I think I'm the only surgeon there. So,
and what type of work do you do?
So look, there's a lot of trauma, and there's a lot of, I mean, a patient with appendicitis doesn't need to travel now 300 kilometers.
When you say trauma, like what?
So motor vehicle accidents, remember, there are a lot of like car accidents. Some of the roads aren't great. So you get a lot of motor vehicle accidents.
And crime and stuff?
And crime isn't really a problem.
So it's not like SMU where Kapus was saying he sees gunshots and stabs every day.
No, you still see stabs now and then, but it's nothing like Gauteng or Pretoria or KZN, you know, that type of trauma. It's more motor vehicle accidents. And
so which is better, private practice or public?
I think it's what you want out of it. That if you want to be part of academia and some rewards that come out of being in public, then public is for you. And also, you're never alone in public.
Okay.
You have a team.
Yeah.
You have a lot of support. So whether it be interns, ComServes, medical officers, consultants, registrars, nurses, you have a lot of support. In private, it's you.
So you're alone?
Yeah.
And M&M meetings and all that stuff, you have to do yourself?
Well, you do it with the other disciplines in the hospital.
Oh, so you still
Obviously,
have those
the hospital manager, is very key to that. And it's not as regulated as public.
Yeah.
But it is something that does happen.
So there might be a private hospital out there that doesn't have these types of things happening.
Yeah.
M&Ms and all.
Well, yeah. Well, I'm generalizing here, but yeah.
Yeah, of course. But the point I'm making is it's not like a standardized thing that is across.
As far as I know, obviously I'm not in management.
Hospital,
and I'm not in management, so I don't know what has to be done, and you know. But we definitely do have them.
Okay.
So it's very different because I don't have an intern to call at 1 a.m. to say if a patient's complaining of pain, or I can't call someone who's junior to me and say, "Can you?" And there's no one on site. So it's me.
That's
so I
scary.
have to drive out and see the patient, and
wow,
you consent the patient, you basically doing everything.
And what's the language there that predominantly spoken there?
So Afrikaans.
Okay, so you're okay with Afrikaans, eh?
Yeah, I'm fine with Afrikaans.
And how long have you been there?
So I've been there since June. So it's been...
So it's like 4 months?
Well, 6 months.
And you settling in?
Yeah, look, I'm enjoying it.
Okay.
I think there's a room for growth, and it's a different side
the hospital?
Of Lenmed.
Kathu.
Yeah, Lenmed Private Hospital, Kathu.
Okay.
So I think there's room for growth in that. From my side, we were never exposed to the business aspect of healthcare.
Yeah.
So it's very interesting how you now have to deal with business, as in the business part of the practice, and patient care.
You don't get trained on that, hey? Like, we don't get trained on those things.
No.
Practice management and stuff, don't you have those courses?
No. So it is very interesting because, I mean, you know, if you don't treat it like a business, you aren't gonna you don't have a salary.
Yeah.
So it's up to you to, if you don't work for 3 weeks, you're not gonna make any money for 3 weeks. And if you don't treat it like a business also.
Well, you have to run the business part, is what you're saying. Properly.
Yeah, but also it's very...
But your patients,
it's a very weird feeling to now have to tell a patient who can't afford something that you can't treat them. Because in public, that's not an issue. So I had to learn that.
That's difficult.
I had to learn to tell a patient, look, unfortunately, you can't.
And then what do you do?
And it's not,
them?
and it's not necessarily the treating doctor. Remember, the hospital itself is a business.
Yeah.
So the hospital fees are something a patient has to pay. So
and that you have nothing to do with that. I mean,
so it's not necessarily the doctor's fee, but it's a different scenario altogether.
So it's going well.
Yeah. So that's quite interesting.
Christmas is coming up. I'll expect a good present soon from you. I'll tell you exactly what
this was your present.
Okay, so what do you do for fun? What do surgeons do for fun? Do surgeons have friends and things?
Well, apparently I don't have any friends, according to you.
Oh, okay.
Yeah.
I wouldn't say that.
No, I mean, look, I think
what do you do for fun?
It is very difficult to achieve a work-life balance.
Okay.
And that's also one of the reasons why I thought leaving public for a little while would be good to achieve that. But I didn't realize that
the other way around.
I didn't realize that.
Really?
Because people have the...
Did you really think that going into private was going to give you more work-life balance? I would think working in the state, you get leave.
No, well, you have to take leave, but you have to take leave within a certain amount. Like you have to discuss it. You have to look at the roster. There's so many aspects, but in private, it's just you. So if I want to take leave tomorrow, I can take leave tomorrow.
Okay. You looked at it from that.
Yeah. But I also thought that I could regulate my hours. Like if I want to do a clinic on a certain day of the week, that's what I want to do. Whereas in public, it's...
Okay, I understand.
Yeah.
So how's that working out? Well, clearly it is working out because you're here now, aren't you?
Yeah.
In Joburg.
Well, it's been different. It's been difficult also. Like, it's been long days and hard work, but I feel like the rewards are also worth it.
Okay.
So like, as you said, now I can take December, whereas I might have had to fight like 5 other people for leave in December.
Okay.
That I've been in public. So
there's a bit more flexibility like that.
Yeah, but
now you're not making money when you're here.
Yeah, but I mean, you plan for it.
Okay.
So you can plan and say, I've done extract lists, or I've done this or that, and then you plan for it, and then you look at January and you book this many for January. So, I mean, it's up to you.
Okay.
Obviously, there are pros to working through December. But also, you need to take time off, or you're never going to get a break.
Okay.
Because it's just you. I don't have another surgeon to rotate with.
Yeah.
As I said, I'm the only surgeon in the hospital.
Yeah.
So unless someone else comes on board, that's how it's going to be. I'm on call every day.
Okay. And then what do you do for fun? You haven't told me. So you just do surgery and think about surgery. But don't you go on holidays?
Look, yeah. So before
you used to travel.
Yeah. So I think Reg time sort of made a dent, and COVID in my traveling plans.
Okay.
So I traveled a lot as a medical officer. Okay. So I think that's definitely something.
Good old days.
Yeah. And then after Reg time, I started traveling again. So I think that's something that I'm definitely going to look at doing. And then I want to get into a bit more, I need to get some goals sorted out. So I'm going to swim the Midma.
Oh.
So I'm going to train.
Sure.
Dr.
Dustin Ramdas, a friend of mine, has done that recently. Speak to him.
Yeah.
We'll get him on the show soon also.
Yeah, it's something I was supposed to do in school and I kept putting it off. Yeah. So I'm definitely going to swim the Midma.
The Midma Mile.
Yeah.
How long is that? 1.6 kilometers. Anything else interesting coming up? Exciting?
Yeah, so I think we're going to start some training, some golf. I want to get into golf.
Oh, okay. Yeah. And Kathu?
Well, Kathu, I live on a golf course, so...
Oh,
so anyone who wants to come to Kathu, it's the 9th best golf course in the country.
We really need to get in. That Dr. Sandhir Bhai Maharaj needs to come to Kathu and meet you, the surgeon that we've been talking about. Because he's a big golfer. Him and Dustin.
Yeah, it's an awesome golf estate and the golf course is great. So my colleague is the radiologist that I work with. He's a trainer.
Yeah.
He trains kids.
Okay.
So I'm going to go for lessons and start playing some golf in the new year, hopefully.
All right, cool. Yeah, but before you buy the golf equipment and stuff, it's Christmas, so my present must come
No,
first.
you were very mean in this interview. So.
Really? Was I? Okay, well, so let's see what the comments on, because the comments have been brutal. Anyway, the last question, it's a bit of the theme on the show. If somebody had to come to you and say, I'm thinking of doing medicine in general, what would you say to them?
Yeah, so, I used to get very irritated when, when I noticed that when someone says, I want to do medicine, and the response was, don't do medicine, it's terrible. And so I mean, you can only tell someone what your experience has been. And, they need to make that decision for themselves. And if you're doing medicine for the right reasons, then I think it's very rewarding.
What's the right reasons?
You should never do medicine to make money.
Okay.
Because there are much easier ways to make money. I'm not saying the money isn't
You tell me the wrong reasons, but what's the right reasons?
No, I mean, the right reasons are if you enjoy dealing with patients. So if you're a people person, if you don't want to deal with people and you want to do medicine, then you're going to have to look at something like hematology or something where you don't interact with patients. But if you don't like patients and you don't like interacting with people, then medicine isn't for you.
Okay.
And then obviously hard work. Because even if you decide, look, I'm doing medicine because I want to do something that's a little less stressful.
It just clicked in my mind. You enjoy working with people, hey?
Yeah, I do.
All right. I see you as an introvert, though, but
just because I behave in a certain way at home doesn't mean I behave the same at work.
All right.
But also, I think, and I'm sure a lot of people in the profession will back me up. When you come home, you just want to do nothing.
Okay.
Because you deal with people and you deal with stressful situations every day and sometimes night. And when you come home, you just want to watch TV and sit on the couch.
I think you speak for yourself.
Talk to anyone.
I know a lot of doctors that come home and then they want to go and play paddle and do this.
Oh, well, yeah.
Yeah.
But anyways.
So you would say, what would you say to somebody thinking of medicine?
Yeah, if you really want to do it, I think first research, shadow someone.
Yeah.
That's the best way to learn.
Okay.
And shadow someone who's going to allow you to come in with them to like some sort of scenario. Go to theater if go to casualty, go sit in a GP's office with them, see how they interact with patients, see if it's something that you're going to like.
Yeah.
And if that's not the good for you, then I really don't think you should do it.
You were talking about coming home and watching TV. I know you do that a lot. Which TV show is like the most accurate representation of like medicine? Is it Grey's Anatomy or is it ER or is it Scrubs or what is it? Any of them or none of the above?
I don't really remember because I was a bit, I don't know, we were a bit young for ER, I think.
I heard Scrubs is quite realistic.
Yeah, but not everyone looks like a JD and, a Turk. So it's not as glamorous as the TV shows, none of them actually. Everyone wants it to be like Grey's Anatomy because they spend more time doing other things than the actual medicine. But I think...
Honestly, it doesn't sound glamorous to me at all. Like, it sounds stressful. It sounds a lot of work. It sounds...
Look, I loved. Honestly, there were bad times, but I loved.
That's fine.
I loved it. I'm glad you loved it. Internship was difficult.
To me, like listening to this, I appreciate actually the openness and because this is what people need to hear. The real story, and they can make up their mind. Some people might listen to your story and think, "I really want to do that. I can't wait." Personally, I'm like, I would not want to do this.
Yeah, well, as I said, you must understand, as with any job, there are going to be times where you wish you hadn't done it. And I think it's certain points in your career as an intern. Also, maybe because I studied abroad, people were not very welcoming when I came back. So my first month of internship was terrible.
Oh, okay.
I really didn't like it. But I got into it and it was the best 2 years of my life. And then, as I said, when you're about to write your first exam, you wonder why you did it, your second exam, things like that.
Okay. And if you didn't become a surgeon, what do you see yourself as?
In terms of still in the medical field?
No, just anything.
Oh.
Yeah.
I have no idea.
Okay,
I've
so
never
you
thought of it.
never thought of it. Okay.
Oh, Game Ranger.
Oh.
But then I don't like, I'm a bit scared of snakes and stuff. So I
Okay,
don't know. But yeah, maybe a Game Ranger. Or something maybe in, as I said, I did arts and drama. So maybe English literature, maybe art, something along those lines.
All right, cool. Well, yeah, thank you for coming on the show. I appreciate it. It was not without much prodding and prying and forcing on my part. So I appreciate it. And I learned a lot, and I hope the people that watch this also learn something. So, and get some good insight. Yeah.
That's your Christmas present. So.
Okay, thanks. I want a new iPad. Okay. Cheers. Thank you.